From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
Welcome to this news roundup. I'm Jennifer Abbasi, Director of JAMA Medical News. Today we're discussing 3 stories. They cover federal funding for rural health care, ongoing IV fluid shortages, and legalized sports gambling. Associate Managing Editor Kate Schweitzer is here. Hi, Kate.
Hey, Jen.
Lead Senior Staff Writer Rita Rubin is here. Hi, Rita.
Hey, Jen.
And we're joined by freelance writer Dr. Eli Kahan, who is a third-year pediatric resident at Boston Children's Hospital, a soon-to-be fellow in neonatal intensive care at Stanford University, and a frequent contributor to JAMA Medical News. Welcome, Eli.
Hello, everybody.
Okay, first we're going to talk about potential federal funding cuts to rural health care in the U.S. Rita, fill us in on what you learned.
Well, about 1 in 5 people in the U.S., or approximately 66 million individuals, live in areas designated by the census as rural. And compared with people living in urban areas, rural residents are more likely to report having a chronic health condition, such as coronary heart disease or diabetes. And they're also more likely to report having health risk factors, such as cigarette smoking or obesity. They tend to be older and have a lower income than urban residents, so that also increases their risk of chronic ailments. And of course, rural residents often live far from medical care, which has been linked to lower use of services, not surprisingly, and a higher risk of mortality. Plus, their driving distance to the closest hospital has been increasing. In the past 15 years, 86 U.S. rural hospitals have shut down completely, and another 65 have been converted to facilities that no longer provide inpatient care but do offer some health services. But budget cuts proposed by the Trump administration threaten to increase health disparities between rural and urban residents, public health experts told me. Congress, of course, has the final word on the budget. These cuts are not yet set in stone, and they might not even be finalized before the 2026 fiscal year begins on October 1st. But President Trump and Health and Human Services Secretary Robert F. Kennedy Jr. have made it pretty clear that they want to eliminate the Health Resources and Services Administration, or HRSA, and home of the Federal Office of Rural Health Policy, which has coordinated rural health programs at HHS for more than 30 years. Some parts of HRSA would be rolled into other HHS agencies, in particular the new Administration for a Healthy America, but a provisional HHS budget dated April 10th mentioned eliminating 4 rural health programs designed to support rural hospitals and attract physicians to rural areas. We're not talking about a huge chunk of the federal budget. The appropriation for the Federal Office of Rural Health Policy for the current fiscal year is $364 million, but the provisional HHS budget would cut it by about 25% to $271 million. Now, a few days after my story was published, the House narrowly passed President Trump's big, beautiful bill, which would cut Medicaid spending by nearly $700 billion. The Senate, at the time I'm recording this, has not yet voted on it. Now, how might this impact rural health? Well, as one of my sources told me, Medicaid payments disproportionately influence the financial health of rural hospitals. For example, a study published in the Journal of Rural Health backs him up. It found that hospitals were more likely to close in states that had not expanded Medicaid, which resulted in greater travel distances. So, we have to wait and see what that $700 billion cut in Medicaid spending will do to rural hospitals.
Rita, one of the programs targeted for elimination in the preliminary HHS budget is the Rural Residency Program. What's the role of this program in improving rural health?
Only about 2% of residency training takes place in rural areas, according to HRSA. But HHS has proposed eliminating the Rural Residency Planning and Development Program, which is what funds the creation of residency training programs in rural areas. Now, whether those training programs help persuade physicians to switch from opening practices in urban areas to rural areas is tough to pin down. After all, some physicians who opt for rural residency programs likely were already planning to settle down in a rural area. But it's hard to dispute that such programs increase rural residents' access to health care.
Okay. Thank you, Rita. And I'm sure you'll keep an eye on this story for us going forward.
Yep.
Let's turn to the ongoing IV fluid shortages in U.S. hospitals. Eli, you wrote about this for us this month. Tell us what's going on.
Yeah, thanks, Jen. So let's try to rewind the clock for a second to maybe the before time. So let's rewind the clock to September. And last September, one of the pieces of news that I know a lot of people were watching was this hurricane, this awful hurricane named Helene that tore through the southeast U.S. And I think doctors, clinicians across the country were as tuned into the news as pretty much everybody was. But what they didn't know necessarily was that it was going to affect them. And even for those who anticipated it might have an impact on them, the severity of the problem was hard to appreciate until it was upon them. Just days after the storm made landfall, Baxter International, which is one of the world's largest drug and device manufacturers, announced that unprecedented rain and extensive flooding had hit one of its North Carolina facilities, forcing it to close. The affected facility, the company's North Clove plant, produced 1.5 million bags of intravenous fluids every day. That meant when that factory shuttered, that 60% of the nation's IV solutions had disappeared from the system overnight. And clinicians maybe have gotten used to drug shortages across the board. Data that we reviewed shows since the early 2000s, there have been more than 100 shortages every quarter. And in recent memories, that's been over 250 shortages every quarter. I think what clinicians didn't necessarily anticipate was that shortages of certain IV fluids like normal saline, lactated ringers, dextrose containing crystalloid would continue to plague the U.S. months after the storm. That's because the storm exacerbated pre-existing shortages of several types of fluid and created new shortfalls. That also happens in the broader context of years of data suggesting that the kinds of natural disasters like Hurricane Helene and Hurricane Maria before it, which impacted Puerto Rico in 2017, posed an existential threat to the nation's medical supply chain, and that these kinds of storms are becoming increasingly common. The shortages also come despite years of work to try to shore up that infrastructure and years of warning that failing to do so could represent a serious risk to the nation's health and security, just like this one. Taken together, those patterns have led people to ask, why does this keep happening? The question really is whether it's a matter of political will or if there's nothing to be done, which I think is a question that a lot of clinicians who see that little animated IV bag pop up on their EMR, imploring them to try oral hydration or other enteric fluids, are asking themselves.
Eli, can you describe how recent federal actions may stand to affect the ability to prevent future shortages or to rapidly, effectively respond to them when they do happen?
Absolutely. I think one of the things that a lot of federal government hawks are watching is the restructuring and the replacement of ASPR, which is one of the agencies responsible for strategic response in emergency situations like this one. And the administration said during the March 27th announcement of the Health and Human Services restructuring that ASPR would be transitioned under the Centers for Disease Control as opposed to kind of where it currently lives independently. The question that a lot of people are asking themselves is what that actually means. There hasn't been much guidance proposed on what that would look like or in what capacity ASPR would continue to exist. And in the federal budget, the president's budget proposed for 2026, one of the key programs overseen by ASPR called the Hospital Preparedness Program, which funds to the tune of millions of dollars across the country efforts on making sure local jurisdictions as well as key facilities themselves have have things like buffer supplies and other strategic mechanisms in place to respond to a crisis, that entire program, according to the 2026 budget, would be cut. I think one of the other things that people are looking a lot at is the potential impact of tariffs, which I know a lot of folks have been paying attention to and thinking about how that might impact lots of different dimensions of the US economy. And supply chain experts say even if there are medical exemptions and pharmaceutical exemptions to the tariff, as there have been thus far, that many of the kinds of things that you need to respond effectively to medication shortages, including shortages of IV medications like fluids, depend on products that wouldn't qualify within those exemptions, such as plastic and other basic materials that you need to produce at scale IV fluids.
Okay, so if we're being our most optimistic here for a moment, can you give some examples of measures the federal government could take to buffer against future threats to the U.S. healthcare supply chain?
Absolutely. And I think optimism's good. I think we can all use a little bit of optimism. But the good news is there are lots of proposals out there that could really buttress this system. Two of the biggest organizations that have been thinking about this are the Brookings Institution, as well as ASHP, which is one of the major pharmacy organizations in the US. And among other things, these organizations propose things like low interest loans to smaller producers so that we're not depending so much on organizations like Baxter to supply 60% of all IV fluid in the country, but so that those loans could be put to use by smaller producers who could in turn build small factories or invest on increasing the size of existing factories so that we do what experts call diversify the supply chain, meaning if a catastrophic hurricane hits North Carolina, that we have facilities in lots of other places that we can also depend upon. There are other more procedural things like waiving fees associated with developing new facilities, as well as expediting applications of facilities devoted to core products like IV fluids that are essential in the delivery of healthcare. There are other things that the federal government could do as well beyond supporting the factories themselves. They could support all the other organizations responsible for bringing in chemicals and other ingredients for critical generic medications, either by, again, exempting the ingredients included in those medications from tariffs, or which would reduce costs to those manufacturers, or on the other side, providing various supplementary payments so that those manufacturers could ensure that there's a consistent level of supply that would allow them to keep the lights on. Those are probably two of the examples. There are lots of other examples that we cite and encourage people to read, but suffice to say, there are actually a lot of good options on the table. Jen, the question a lot of experts are asking is, do we have the political will and ability to get policies like those passed in today's environment in DC?
Okay. Thank you, Eli. Always a pleasure having you on the show.
Thanks so much, Jen.
Finally, Kate, you wrote about the hidden health costs of sports gambling in the U.S. This is an issue of growing concern with the explosion of legalized sports betting. So what's important to know?
Thanks, Jen. So, yes, sports betting these days is pretty ubiquitous. It seems everywhere you turn, there's an ad for it. This year's Super Bowl took place at Caesars Superdome, a stadium named after a casino. March Madness bets hit a total of $3.1 billion, a 15% spike over the previous year. It reached such a fever pitch that the NCAA issued ads warning losing gamblers not to harass its players. In the 7 years that sports betting has been effectively legalized across the U.S., the growth has been exponential. But as many often ask, what's this got to do with health? Well, experts have noticed another surge too. Alongside this rapid expansion of sports betting venues, particularly those operating online, the nation seems to be facing a similar rise in gambling addiction and a host of other detrimental effects. Because it's not just financial security that's at stake here. Studies have linked sports betting to alcoholism, domestic violence, and mental health issues, including suicide, and researchers worry that those implications are going unnoticed. So how did this influx of sports betting take hold? The quick history lesson is that sports gambling had been prohibited in all but a few states under the Professional and Amateur Sports Protection Act of 1992. The Supreme Court overturned this act in 2018 in a decision that changed the American gambling landscape for good. Now, 38 states have legal sports betting, and not only through brick-and-mortar sports books. Online operators offer unfettered access to the point that 94% of all sports wagers are online bets. People don't even need to leave the comfort of their homes to gamble in this way. So what was once a fringe activity reserved for a trip to Vegas can now be done anytime, anywhere. And as such, the nature of it has evolved too. People are increasingly comfortable betting on less popular sports. It's not just the NFL, it's the minor leagues or it's cricket. And it's not just betting on odds of who will win. It's parlays and slot machine or lottery style bets, like which color Gatorade will be thrown on the winning coach. So it's just been this massive cultural shift, one that has A, normalized the activity, and B, requires far fewer barriers to entry. And of course, it's incredibly hard to measure the effects of this shift, right? It's hard enough to even measure the health risks of gambling in general. As one expert noted, unlike research that tracks opioid addiction, the cause of death is never, quote, gambling. A recent study, however, pointed to a 23% jump in online searches seeking help for gambling problems in the years since the 2018 ruling. And in the states that allow online betting, those spikes are even higher. Ohio, for instance, experienced a 67% increase following the establishment of sports books.
So, Kate, what makes sports betting and sports betting addictions so different from the broader category of gambling and the negative effects of gambling in general?
The most obvious difference is the demographic it attracts. Most sports bettors are young men with disposable income and higher education. Although that may seem safe enough, this is a group that's far riskier than any other. And sports bettors tend to gamble with more frequency and in a greater variety of ways than non-sports gamblers. So someone who bets on sports may be more likely to also play poker or do scratch cards, as an example. Researchers have also explored how sports betting coincides with drinking. They consume more alcohol, not just the non-gamblers, but gamblers who don't bet on sports. So it's very distinct to sports betting. One expert I spoke with is planning to study the rates of DUIs since sports betting legalization. And the hypothesis, of course, is that they will have gone up. Also troubling is that sports betting is starting to skew much younger. A recent study found that middle school students who took part in underage gambling mostly placed bets on sports. And the authors of that study considered it a gateway to problematic gambling.
So what's to be done? How is sports betting regulated, and what reforms should we expect to see or hope to see?
Right. So when the Supreme Court made its determination, public health was decidedly not part of the equation, nor was it a factor in much of the legislation that followed. In 2023, the average state allocation of funds to address gambling addiction was about $3.1 million. And that's for services like gambling prevention programs or gambling treatment. But when you dig into the data, that amount was largely driven by one state. Massachusetts earmarked $22.6 million. But more common were states like Wyoming, which allocated just $300,000 in annual tax revenue to such services, or New Hampshire, which dedicated only $100,000, despite collecting more than $35 million from sports bettors in a single year. And that's the thing. There's so much money being made in sports betting. Wagers increased from $4.9 billion in 2017 to $121 billion in 2023. And that same year, states collected nearly $2 billion in taxes from it. And yet, reports indicate that 5 million people in the U.S. meet the criteria for compulsive gambling, yet only 8% even seek help. And whether that support is even there is another story. So this is an obvious first step in reform, the requirement of sportsbooks to contribute much more significantly to gambling addiction services. One expert called it a common sense tax increase to account for the public health costs of what's easily the fastest growing source of state tax revenue. Beyond that, it's, well, should we even be allowed to place bets on our phones at all? Some countries have banned the practice of online betting. Similarly, it may help to enforce mandatory breaks and limits on individual wagers. And perhaps we don't allow the use of credit cards to place bets and only allow for debit purchases in that way, which, that connects to the financial ramifications in all of this. And finally, similar to regulations that the tobacco industry was forced to put in place around advertising, marketing needs to be better regulated as well. Class action lawsuits have already been filed against sportsbooks that promoted, quote, risk-free bets to entice new users, which was frankly deceptive and exploitative to the sources I spoke with. Clinicians also have a role to play here. Because of gambling's connection with substance use disorders, physicians should be better prepared to ask about gambling the same way they ask about alcohol, drug use, depression, anxiety. A good place to start is by asking questions that relate to these, quote, lower risk gambling guidelines. One source explained it to me that they're a series of research-based protocols that lessen the harmful effects of gambling. So you could ask, how many days a month do you gamble? Because the benchmark is no more than 4 days per month. Or how many types of gambling do you participate in? Because they shouldn't regularly gamble in more than 2 forms. That sort of approach. And of course, it won't be easy because problematic gambling is so difficult to diagnose. So we'll have to see how this all plays out and what these future studies will find about further effects sports betting has on health.
Thank you so much, Kate. Really interesting. All right. If you'd like to learn more, we'll include links to the stories we discussed in the show description. And you can find all of our stories at jamamedicalnews.com. This month, we also covered a new study from JAMA Otolaryngology Head and Neck Surgery about why the sense of smell is a marker for mortality risk. That's a really interesting piece written by Virginia Hunt, our editorial intern from Northwestern University's Medill School of Journalism. Rita Rubin covered the U.S. government's plan to phase out petroleum-based synthetic dyes from the nation's food supply. And Rita also wrote a great piece on research into the increase in early onset colorectal cancers in people younger than age 50, sometimes much younger. We had a great piece on nutrition's slow integration into physician training, an important story written by freelance writer Emily Harris, who is a medical student herself at Harvard University and another frequent contributor to our pages. And staff writer Samantha Anderer covered a new global initiative called the Human Exposome Project, a complement to the Human Genome Project. Check it out to learn about the concept of the exposome. And finally, we had an interview about how machine learning could be used to target nudges in healthcare settings. You can find that episode in this show's feed, at JAMA Network's YouTube channel, or at jama.com. Or better yet, follow the JAMA Network podcast, JAMA Plus AI Conversations. That's it for this JAMA Medical News Summary. I'm Jennifer Abbasi. Thanks to Rita Rubin, Kate Schweitzer, and Dr. Eli Kahan. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening, and join us again next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.